Hello, everybody. I hope you are doing well. I would like, first of all, to thank the organizer for inviting me, and I would like to congratulate them for this nice congress for the Lebanese Pulmonary Society. And still, I would like to talk a little in French since our guest is Dr. Karen Leroy. Donc, bienvenue, Dr. Karen. Dr. Karen Leroy is a medical doctor specialized in medical biology with PhD in genetics. She was recruited as molecular oncologist in Paris-Créteil on 1998, and then after was appointed as professor in 2007. She moved to Paris-Descartes, and then after also to Henri Mondor, Créteil. In 2015, she went to Cochin Hospital, where she is now. So her career was always in Paris. She's lucky. Dr. Karen Leroy, Professor Karen Leroy, has conducted several studies based on transcriptomic analysis of B-cell lymphoma, which is very important. And nowadays, she's focusing her research on genomic biomarkers that can be used to improve the quality of care of patients. And we know that nowadays, genomics for us oncologists is really very important. So please, Dr. Karen, the floor is yours. The floor is yours.
First of all, I would like to thank the organizers for inviting me to participate to the Lebanese Pulmonary Society meeting and to present the current guidelines for molecular testing in lung cancer. Here are my disclosures, so I leave you a few seconds so that you can read it. So, as all of you know, the vast majority of patients with non-small cell lung carcinoma will be diagnosed at an advanced stage, and there will be little tissue available for diagnosis and molecular testing. It is a challenge for the pathologist to provide an accurate histological diagnostic with as few immunostainings as possible to perform the theranostic immunostainings which are required, and to spare some tissue sections for DNA and RNA extraction. The ESMO has recently released updated recommendations for treatment strategy in non-small cell lung carcinoma. I will start with squamous cell carcinoma because it's quite simple. PD-L1 staining of tissue sections is mandatory to identify the patients with high level of expression of PD-L1, more than 50% tumor cells, to consider the possibility of anti-PD-1 as a single treatment. Molecular testing should be only considered for the patients who are never smokers or former light smokers. In non-squamous, non-small cell lung carcinoma, that's adenocarcinoma, but also large cells, not other specified, and so on, PD-L1 staining is mandatory to consider immune checkpoint inhibitors in patients with high expression of PD-L1, or to go to combination with chemotherapy. But molecular testing should be performed upfront before treatment, because it's well known that patients with oncogenic addiction will poorly respond to immunotherapy. As you know, the 4 classical biomarkers that should be tested at diagnosis are listed here. You have EGFR mutations, because the patients with this EGFR mutation will benefit from TKI targeting the mutated receptor. For BRAF V600 mutation, you will consider the combination of anti-BRAF, BRAF inhibitor, the BRAFenib, and MEK inhibitor, trametinib. For ALK fusions or ROS fusions, there are specific TKI, and currently alectinib is the preferred drug for patients with ALK translocation. This publication listed the appropriate method to be used to test for these alterations, molecular alterations. Usually, people use molecular biology to search for EGFR mutations or BRAF mutations. Currently, most of the laboratories will use immunohistochemistry to screen for ALK rearrangement or ROS1 rearrangement. In the case of ROS1 rearrangement fusion, you have to confirm the presence of the fusion by FISH or molecular biology techniques, because you've got some false positive or false negative cases. For ALK rearrangement, if you have a strong staining, 3+, it's considered to be enough to go for therapy. So that were the four markers that you know well, because we are using these biomarkers since several years. But there are three new ones which have been highlighted in a recent publication of the ESMO Working Group on Precision Medicine. It is now known that patients with non-small cell carcinoma, non-squamous non-small cell carcinoma, with MET exon 14 mutation, RET fusion, or NTRK fusion will benefit from targeted therapies. And therefore, all these biomarkers are considered as ESCATE level 1, that is the ESMO scale for clinical actionability of molecular targets, to be considered as clinically validated to be used for treatment decision. There are 4 other markers which are coming up, and they are listed here. That's EGFR and ERBB2 in-frame exon 20 insertions, small insertions, MET amplifications, and KRAS G12C mutations, for which there are currently clinical trials to indicate, to precise, to define the population that will benefit from targeted therapies, and to precise the extent of clinical benefit. But that will be also patients who can have benefit from targeted therapies. Right now, the ESMO Precision Medicine Working Group recommended, that's very recent publication, that tumor multi-gene next generation sequencing to be used to assess this level 1 alterations that I have shown you in the previous slide. Next generation sequencing means a lot of different things. You can perform next generation sequencing with DNA or RNA. You can use small targeted panels or very large panels with hundreds of genes. You can sequence the exome or the genome. What's very important, in my opinion, is whatever the test you use to analyze a lung cancer, it has to show a high sensitivity and specificity to detect the genetic alterations that you are looking for. And I would like to illustrate this point with MET exon 14 mutations. So I would like to illustrate this point with MET exon 14 mutations. As you know, probably, MET is a tyrosine kinase receptor located at the plasma membrane. You can see that on the left part of the slide. The exon 14 of the gene encodes a domain which regulates the degradation of the receptor. When this exon is missing, this exon is skipped, the receptor will accumulate at the plasma membrane and signal actively. In the middle figure, you will see that the mutations that give rise to MET exon 14 skipping are located in the 5' or 3' part of the exon 14. And these are small deletions that extend in the intronic regions that stand beside this exon. Right part of the slide, we realized that when we started testing for these MET exon 14 mutations, the panels which had been designed for NGS did not include the intronic regions which are mutated in these cancers. You can see on this panel that the exon 14 is the blue box, and it was only sequenced, that's the pink and blue stripes there, was only sequenced partially, and most of exon 14 skipping mutations were indeed missed. So the laboratories had to make their techniques change in order to be able to detect correctly MET exon 14 skipping mutations, and now that's what they do. Another technological point which is quite discussed nowadays is how to detect all these rearrangements of ALK, ROS, RED, NTRK, and so forth. You can try to capture DNA or RNA and sequence the regions of the genes to identify the fusions. You can use targeted RT-PCR and sequencing to detect known fusions. You can also use a technology that was developed by Archer, and which is quite set up in France, using a targeted primer in the gene of interest to prime for the fusion detection. And this technology is very sensitive, and it allows to detect known fusions and new ones. That's why people like it, but you have to use RNA as starting material. Another important issue in lung cancer testing is when to use liquid biopsy. You know that when I speak about liquid biopsy, I am thinking of circulating plasma DNA. This plasmatic DNA comes from the diverse normal and abnormal tissues of the individual, cancer or non-cancer. And usually the tumor fraction is very, very small. It's recognized that you should test plasma at diagnosis to look for EGFR mutations if there is no tissue available for molecular testing. This has been shown very largely. And it's also accepted that you should try to sequence EGFR ALK in the plasma when patients progress under first generation or second generation TKI targeting EGFR or ALK. Right now, there are a number of papers and also commercial publicity indicating that you can use plasma comprehensive genomic profiling to search for many mutations, but also fusions and amplifications. You should consider the sensitivity of this comprehensive genomic testing and be sure they are sensitive enough to detect what you are searching for. But probably it's the avenir. To illustrate this point, I will come back to the detection of mutations associated with resistance to EGFR treatment, TKI treatment. You know that EGFR mutations, the driver mutations that are sensitive to therapy, are located in exon 19, that's small in-frame deletions, or exon 21, usually the L858R mutation. When people are treated with first or second generation TKI, in more than half of the cases, there will appear a resistance mutation, T790M, that will prevent the binding of the drug to the mutated receptor. However, it's been shown that you cannot always detect this resistant mutation in the plasma. This slide shows you a poster that was presented at the ASCO meeting 2 years ago, and that was very illustrative of this specific point. They have looked to patients included in AURA trials. These patients had progressed under EGFR TKI and had a resistant T790M mutation in the tumor tissue. When they looked to the plasma with very sensitive techniques, NGS, beaming, digital PCR, you can see on the slide that when there are more than 5% driver mutation, you can detect very easily the resistance, the T790M mutation. But when the driver fraction drops below 1%, in many cases, you cannot detect the T790M mutation. So when you test the plasma in a patient who progress and you get a negative results or a low fraction of activating mutation, you should consider that you cannot interpret the result and you don't know whether there is or not a resistant mutation T790M. Treatment with osimertinib, which is the third generation TKI targeting EGFR, that was developed to be efficient in patients with this resistance mutation, has challenged our way of seeing how resistance proceeds in lung cancer. This publication showed the mechanism of resistance to osimertinib in patients receiving first-line or later lines treatment with osimertinib. And the resistance which is linked to EGFR receptor on target, that's amplification or mutations, are shown in blue. You can see that in a large proportion of cases, the mechanism of resistance that arise after osimertinib are transformation, histological transformation in squamous cell carcinoma or small cell carcinoma, or off-target mechanism, that is mutations, amplifications, or fusions of other genes. When patients receive osimertinib as first-line therapy, which is recommended right now, for instance, in France, these mechanisms are predominant. And there was therefore a very recent review considering what to do when patients would progress under this treatment. And I highlighted the recommendation to go to tissue biopsy of the progressing lesion rather than test the plasma in this setting. And I think this illustrates very strongly the fact that we have to adapt the strategy of testing, the sampling, the techniques to each situation. You cannot make a general rule. This is going to change according to the specific genetic alteration at start, the targeted therapy which the patients receive, and the time of treatment where you are and what's happening clinically. To finish the talks, I would like to have just a few words for biomarkers to consider for immunotherapy. And I'll go quickly through this slide. PD-L1 immunohistochemistry staining has been standardized, and there are recommendations about which antibody to use and which is not so good. And it also depends on the technology that you will, the specific techniques you will use to reveal the antibody binding. It's the gold standard, even if it is not perfect. The tumor mutational burden, tumor mutational load has been clearly shown to be associated with response to immunotherapy, but as this biomarker is really difficult to standardize, and it didn't make it through the different clinical trials. So right now it's not used. The second point, which is important to notice, is that TMB was really strongly associated with response to immunotherapy when patients received anti-PD-1 alone. But when they, in the trials, when they combined anti-PD-1 and anti-CTLA-4, or when they combined chemotherapy and immunotherapy, the biomarker didn't make it. So that's why it's an interesting biomarker, but it's not used currently in lung cancer testing in routine. As far as we look to gene expression signatures, our group and others have shown that the gene expression signatures that is characteristic of a hot tumor with an inflamed microenvironment is also associated with response and survival. But it didn't make it in routine for the same reasons as TMB. That's difficult to standardize and also didn't make it in clinical trials. So I hope that I gave you a quick overview of the molecular testing as we do it right now. In our institution, that's Cochin Hospital in Paris, and I must say that the strategy is changing, is evolving quite rapidly, and we discuss this strategy with the pulmonologist, with the oncologist, with everyone involved and the pathologist, with everyone involved in the clinical care of these lung cancer patients. And that's a moving field, and it's very interesting to follow up. Thank you for your attention.
Thank you. Thank you very much, Dr. Akkar and Professor Kain, for this very nice presentation. I would like to, I've opened the floor for questions. Meanwhile, since I don't see question, I have myself many questions for you. The first, so you are saying that you still prefer the tissue biopsy, while, for example, in other organs like breast cancer, there has been a study showing that between the liquid biopsy and the tissue biopsy, there might be some discordance, but globally they met common alteration. They found common alteration. For example, in a SOLAR trial breast cancer, some mutation or some alteration found in liquid biopsy couldn't be found in tissue and vice versa. But the results were acceptable. So in lung, you prefer always to go for liquid biopsy. That's the message. Yeah?
No. I think at diagnosis, it's very well known. Well, I think when it's possible, it's better to study the tissue, because the fraction, the tumor fraction, is always higher in the tissue than in the plasma. In the plasma, when you are at localized stage, there is really very, very little tumoral DNA. You need an advanced stage to really have tumor DNA in the plasma. So when you are at an advanced stage, metastatic patient, if you have tissue available for molecular testing, it's better, because the mutation is at a higher level, and you can also look for fusions and so on, amplifications. When there's no tissue left, that's the problem, at diagnosis with lung cancer. Then you can use the plasma to search for EGFR mutation. It's really validated. It's just there's no problem. Currently, there are some new tests with comprehensive genomic profiling, but right now we don't know exactly the sensitivity of these tests to detect fusions or amplifications. I mean, if you look for a GFR, it's okay, but if you want to go more, you can use it. If it's positive, it's good. If it's negative, maybe it's still there. Mm-hmm. And the question I wanted to raise in this presentation was the question of progression, because at progression under targeted therapy, it was recommended to use liquid biopsy when patients received gefitinib or erlotinib or afatinib. But now, when patients receive osimertinib, the situation is not the same. Maybe if you just look to the liquid biopsy, you are going to miss the mechanism of resistance. And in this setting, it may be better to go to the tissue.
Okay, just to remind our audience that usually we search for alteration, any alterations in the genomics, and we have 4 types of alteration, and some of these alterations cannot be found by the classical NGS. It's true, Dr. Karen, yeah? That's why the liquid biopsy might miss some alteration, which might be mainly fusion or amplification.
Exactly.
Better with the RNA or with the IHC testing.
Yes, exactly. The mutations, the sequencing, when it's a punctual mutation, you can find it with the sequencing. But for fusion or amplification, as you say, rearrangement of genes or gain of copies, it's more complicated to get the information on the plasma.
Okay. Another question from my side also. Is the liquid biopsy, hello?
Yeah.
Is the liquid biopsy related to the bulk of the disease? Is it possible to say that if the bulk of the tumor of metastasis is low, we have less chance? I don't know. What do you think?
Yes, it's proportional to the bulk of the disease. Really, it's been shown. The more the disease is bulky, the more DNA, tumor DNA you get in the plasma. True.
Okay, so thank you. Is there any question, Infomed? Can you please guide us? I don't see any question in the chat box.
Neither do I.
Okay. I will finalize with the question. Even if it's, I will ask about Foundation 1 and the Guardant. Recently, both were approved as liquid biopsy testing. I think, do we have any other test for liquid biopsy outside the institutions, to your knowledge?
Well, there are some others. The 2 you mentioned, the FMI and the Guardant, are very well known. I think there are a few other companies who can provide also testing on liquid biopsy. Okay. I don't have the name right now.
Yes. Thank you very much, Professor Karen. On va plus accepter votre présence par media. We would like to see you the next time in Beirut. You will even with what's happening in there. Thank you very much.
Ça me fera très plaisir. Je vous remercie beaucoup et j'étais très contente de participer à cette session virtuelle. Merci beaucoup.
Thank you very much for your really nice presentation. Now we will move to Hi again. It's with great pleasure that I will be presenting really a friend and an eminent oncologist, Dr. Hadi Ghanem, who is an associate professor at the Lebanese American University and who's extensively involved in medical students and resident teaching. Hadi is the chairman of the Hematology Oncology Division and the founder and director of the Hematology Oncology Fellowship Program at LAU Medical Center Risk Hospital. So he's really very active. He is American board certified physician in internal medicine and in hematology oncology. Now he is the head of division at Risk Hospital for the hemato-oncology department. He's a French and English educated, so bienvenue, Dr. Hadi. He's a graduate from St. Joseph University, then after he moved to USA, New Jersey, then after Washington, and Houston, MD Anderson, with many activities and a specialty in acute leukemia. But nowadays he's working in all oncology fields. He's well recognized and has a lot of awards, and it's always a pleasure to hear you, Hadi. Today, he will be presenting for us the role of Imfinzi as immunotherapy in lung cancer. So it's really an important topic. The treatment of unresectable stage 3 non-small cell lung cancer till now was really hard for us. We used to be waiting for the relapse. Now we have the chance to cure such patients. So with that, I will give the floor to Dr. Hadi Ghanem, who will present the Imfinzi Symposium of AstraZeneca. Please, Hadi, the floor is yours.
Thank you very much, Dr. Farhat. It's a pleasure to be part of this activity. I would like to thank the LPS organizers for allowing me to present this data, as well as AstraZeneca, who have sponsored this symposium. So again, as Dr. Farhat very nicely introduced, non-small cell lung cancer has, especially the stage 3 disease, has been very challenging as far as the treatment is concerned. And in the next 30 minutes, I will show you why in the past 2 to 3 years, things have really changed as far as the treatment is concerned. And we are excited to share this data from the oncology standpoint with you. So today, our talk will focus mainly on a drug called Imfinzi. And Imfinzi is basically a monoclonal antibody that is indicated for the treatment of patients with unresectable stage 3 non-small cell lung cancer, whose disease has not progressed following concurrent platinum-based chemo and radiation. And I will walk you through the data first to see what's the current landscape in stage 3 non-small cell lung cancer, then to highlight the rationale for the use of Imfinzi following chemotherapy and radiotherapy, and then I will provide a detailed overview for the Pacific trial, and this is the name of the trial that you guys will need to keep in mind, because it's the only trial today that has shown the efficacy and tolerability of utilizing a monoclonal antibody and immunotherapy in the treatment of lung cancer. And then I'll discuss some patient cases that highlight the eligibility of patients to receive durvalumab. So what's the current treatment landscape in stage 3 non-small cell lung cancer? And I'll show you that stage 3 non-small cell lung cancer is really not one disease. Most of our oncology tumor board presentations in lung cancer will focus on, as it's really what we need to work on in a multidisciplinary team. And the examples that we have right here on the screen for you are 3 examples of different stage 3 non-small cell lung cancers that are now classified into stages 3A, 3B, and 3C. For example, when we have a stage 3A, you can have either a smaller tumor that we classify as T1A, T2 until T2B. However, you have what we call N2 disease. Mainly in this area right here, you have a subcarinal lymph node that will make it an N2 disease. However, you can also have a bigger tumor, that this is what we call a stage 3, T3 or T4, with N0 or N1. So here we don't have subcarinal lymph nodes. However, the tumor is bigger, so that's still a stage 3A. You can have a much bigger tumor. This is what we call a T4 disease. Even if it's an N0, it will make it a stage 3A. Now, when you go into stage 3B, you have example of tumor sizes right here. For example, a smaller tumor, however, with N3 disease, meaning contralateral lymph nodes, or even a bigger tumor with N2 disease. And stage 3C would be a bigger tumor with N3 disease, mainly a paraesophageal or paratracheal lymph nodes. So all these tumors are classified as stage 3, and this, as you can see, this is a very heterogeneous disease and can have different treatment implications. This is why it's very important to review all imaging for stage 3 disease patients in a multidisciplinary team approach. So until a couple of years ago, this is what we used to have as far as the treatment goal was concerned. The patient who radiation, this is what we call concurrent chemotherapy and radiation. And after that, they will be placed on what we call active surveillance. And active surveillance means technically that the patients are routinely monitored for disease progression. So technically, no treatment after chemotherapy. Unfortunately, up to 90% of the patients with unresected disease will eventually progress to metastatic non-small cell lung cancer. That's 1 patient out of 10 that will make it at 5 years without progression, and only 15% who would survive this stage. So there was clearly an unmet need in this category of patients. And where did it come from? So this is basically one of the major questions that we had in the past couple of decades, knowing whether a concurrent approach would be better than a sequential approach. And as you can see from this graph, this is a study that was published in 2003 and follow up in 2010 and 2015. You can see that treating patients with stage 3 non-small cell lung cancer with a concurrent approach, which is what we see in the red curve, is better than doing a sequential approach. That means radiotherapy followed by chemotherapy. And as you can see here, the concurrent chemotherapy radiation, the overall survival benefit over sequential is around 5% at 2 years and 4.5% at 5 years. So technically, that was the best we could do until a few years ago. Again, the same studies. Here we're showing the progression-free survival. Again, those numbers are that important in that kind of scenario. Here, what we see is that consolidation chemotherapy has sometimes shown that we have some role for it in patients with stage 3 non-small cell lung cancer. However, this study published in 2015 has settled the issue, which showed that usually we don't really give chemotherapy after concurrent chemoradiation because the survival, after all, the long-term survival showed no significant advantage for doing so. And this is basically why until the Pacific study, there had been very limited advancement in systemic treatment. And you can see here from that landscape that back in the 1980s, it was followed by radiation would make it better. And then we used cistoposide. Then multiple other chemotherapy regimens like cisplatin or carboplatin and paclitaxel were used until that study that I just showed you, the RTOG trial 9410, that showed that concurrent chemoradiation was better than sequential chemotherapy. But then for around 10 years or so, from 2011 to 2018, we had nothing new in that area. So basically, all these trials have shown that you cannot do any better than concurrent chemotherapy plus radiation in those patients who have stage 3 lung cancer that are unresectable. And this is where the Imfinzi or durvalumab Pacific study came into play in 2017, 2018, when we started to see the first updates on that trial. And that trial basically really defined what we do today and has changed the complete landscape of stage 3 lung cancer. So where is this coming from? So there was initial reports about the role of immune system following radiation therapy. And as some of you may know, radiation does induce what we call tumor cell death. And when a tumor dies, what it does is that it releases a diverse array of tumor antigens. So you have to picture that those antigens are actually released in the bloodstream. And when they are released in the bloodstream, what we have is what we call an upregulation of a ligand called PDL1, or programmed death ligand 1. And that PDL1, what it does in the body is that it inhibits the increased T cell activity, and that promotes tumor regrowth. So the rationale was to try to inhibit that PDL1 whenever it's upregulated. And we knew that radiation therapy does upregulate the PDL1. So technically, the idea behind Imfinzi or durvalumab was to block those PDL1 that were overactivated, or the antigens that were released by radiation. So that should reinvigorate the T cells and hopefully enhance the immune response. So this is what Imfinzi does, or durvalumab. You can see here on the left side of your screen, you have the tumor cell, and that tumor cell expresses PDL1. In the middle of your screen, you have the T cell, and that T cell has a strong interaction with the tumor cell on one side. PD1 and PDL1 can be expressed. It is important to remember that the interaction between PD1 and PDL1 will inhibit the immune cell from working on the tumor cell. When Imfinzi is in play, what it does is that it inhibits that PDL1 from the PD1 interaction. So technically, it's as if you were unleashing the T cell to go and try to fight those tumor cells. And this is exactly what Imfinzi does. It blocks the PDL1 to reinvigorate the T cells. That way, it will enhance the immune response. So how does immunotherapy in stage 3 non-small cell lung cancer looks today? So technically, as we said, approximately 1/3 of the patients present with stage 3 disease. The majority of the unresected patients will eventually progress into metastatic disease and die from that disease, which is why we're thinking that there was an unmet need. And now I just showed you that the PDL1 pathway plays a key role in tumor progression, especially when the tumor is radiated. Those antigens are released, and when those antigens are released, you have to reinvigorate the T cells to try to enhance that immune response. So Imfinzi or durvalumab, it's an IV, it's an injection, and that is the first and only approved immunotherapy to improve the overall survival and progression-free survival in stage 3 non-small cell stage 3. And where did that patient come from, or where did that recommendation come from? This is all from what we call the Pacific study, which is a pivotal phase 3 study using Imfinzi in this talk. I will show you the data that comes from Imfinzi, and this is a very important one because it really, as I said, has reshaped the way we treat stage 3 non-small cell lung cancer. And basically what they did in these unresectable stage 3 non-small cell lung cancer, every patient received platinum-based chemotherapy as well as radiation therapy. So this is what we call concurrent chemotherapy and radiation. And what they did is that there were at least 2 cycles of chemotherapy that were overlapping with radiation treatment. And then for patients who did not progress after chemotherapy and radiation, and you know, unfortunately, some patients do progress, but they only took the patients who did not progress after chemotherapy and radiation. And within 1 to 42 days after finishing their treatment, they were randomized 2-to-1 to either receive Imfinzi, which is durvalumab, at the dose of 10 milligram per kilo IV every 2 weeks for up to 12 months. So that's basically 24 injections versus placebo. And technically what they did is that they followed the co-primary endpoints, which were overall survival and progression-free survival, along with other secondary endpoints, including overall survival at 24 months, PFS, health-related quality of life, as well as safety and tolerability. To note that the chemotherapy that was used in this trial could be any of the chemotherapy that we use in real practice, being either etoposide, vinorelbine, paclitaxel, etc., and that 92% of the patients had received the total dose that is now recommended for the concurrent chemotherapy and radiation. So to note as well that patients were also enrolled in this trial regardless of their PDL1 expression and regardless of the EGFR ALK status. So in this slide, I show you the baseline demographics and characteristics, which were very well balanced between the Imfinzi group and the placebo group. As you can see, this really reflects the practice that we have, meaning that most of the patients are men. Their median age is around 65. Most of them are actually either current or former smokers. And all of the patients that were included in this study were either stage 3A or 3B, and they were mainly non-squamous by histology. And as you can see, PD-L1 was overexpressed over 25% in around a quarter of the patients, and most of the patients did have a good performance status. So here I'm showing you what made this study a very important one and that shaped the way we treat non-small cell lung cancer today. It's because we have an overall survival advantage, and that is for the intention to treat population. As you can see here from the red curve is basically the patients who have received Imfinzi, and the green curve is the patients who have not received Imfinzi after concurrent chemoradiation. And when you look at these curves, you can see that they actually split very quickly, and the split continues to grow over time for a median overall survival that has not been reached for the Imfinzi patients versus 28.7 months for the patients treated with placebo. So here you can see that there is a 32% decrease in the risk of death, and that 32% decrease in the risk of death has a very significant hazard ratio with a p-value of 0.0025. When you look as well as the updated data from the 3-year overall survival data that was followed up in a publication in the ASCO meeting of 2019, you can see that even at 3 years, that median overall survival has not been reached yet, and the 36 months overall survival rate is still at 57% in the Imfinzi group versus 43.5% in the placebo group. So that would actually be translated into a 14% advantage of overall survival rate at 36 months, which is very significant in that patient population. Same thing for the PFS. You have a 16.8 months versus 5.6 months, hazard ratio of 0.52. PFS and OS were met at the first planned analysis. And as you can see from this forest plot right here, I will not go into the details, but you can very clearly see that all patient subpopulations did actually benefit from the treatment with Imfinzi at time of no progression, either for overall survival or for progression-free survival. Now, moving on into the secondary endpoint, which is one of the very important endpoints, being the quality of life for these patients, because here we're comparing an active treatment versus placebo. So basically, we want to make sure that those patients receiving the active drug are not getting a worse quality of life. And as you can see from this data right here, that there is no significant change from the baseline in overall health-related quality of life at week 48 in patients receiving Imfinzi versus placebo, which again tells us that this treatment should be considered in all this patient category. So the PACIFIC regimen that I just showed you is really a comprehensive treatment plan that reflects the clinical practice. Why does it reflect the clinical practice? Because as I showed you, the chemotherapy that is used can be any of the treatments that we use nowadays. The chemoradiation treatment being a concurrent treatment is the standard of care that we use today. And technically, Imfinzi has been given to all these patients who did have a stage 3 lung cancer who is unresectable. And technically, there was no other choice in this patient population as per the previous guidelines. So as you can see here, Imfinzi had to be initiated very quickly. And the reason why we're saying this, in the trial, they mandated that Imfinzi should be started between day 1 and 42 after completion of chemotherapy radiation. But one of the interesting findings that we're able to report was that the patients who received Imfinzi within the first 14 days after finishing their concurrent chemoradiation did actually better than those patients receiving it after 14 days. So it is very important to try to enroll those patients on either on trial or on the program receiving Imfinzi as quickly as they can, of course, if they have a good tolerance of the previous treatment, so they can get the most benefit out of the Imfinzi. Now, as far as the adverse effects are concerned, you can see in this table all the adverse effects that are related to Imfinzi on this left side versus the grade 3 and 4 related to Imfinzi. And as you can see here, when you look at the grade 3 and 4 toxicity, which is really what is the most important for us, because that will entail those reductions or interruptions or even discontinuation of the treatment, you can see that all of these grade 3 and 4 toxicities are really in the 1 or 2% range, and most of them are basically manageable. I will show you more details about some of the important toxicities that we have to monitor along with our pulmonologist, because it is important as these patients have, most of the time, they have lung symptoms, they are COPDers, they have history of smoking, etc. It will be important to identify what we call a pneumonitis or radiation pneumonitis versus immunotherapy-induced pneumonitis. And this is important for us to identify. So that category of patients who have grade 3 or 4 pneumonitis or radiation pneumonitis, it occurred in around 3.4% of the patients on Imfinzi versus 2.1% on placebo. And the grade 5 adverse reactions did occur in as many patients on Imfinzi as in the placebo. So technically, the fatal pneumonitis or pneumonia were reported at similar rates between the Imfinzi and the placebo group, at least in the Pacific trial. So when you look at those grade 3 and 4 toxicity, as we said, pneumonitis is up here with 1.7%. You can see that the other immune-related toxicities that we tend to see with all immunotherapy regimens are really less than 1%. So we kind of know by now how to manage these toxicities. It is important to recognize them early and treat them. So how do we give Imfinzi? Imfinzi is as we said, an infusion. It's given over 1 hour. It's every 2 weeks. It's usually well tolerated. It's a quick infusion that we give in our 1-day chemotherapy unit. And based on the Pacific protocol, we usually give it for 12 months in the absence of disease progression, of course, if the patient has no unacceptable toxicity. So how do we manage those immune-related adverse reactions? So this is what IMAR stands for. And we kind of have very specific guidelines as oncologists to manage them. It is important to work very closely with our pulmonologists to identify the immune-mediated pneumonitis, which can be either grade 2 or less. In that case, technically, we just hold Imfinzi and then wait until it resolves to continue it. But whenever the patient has a grade 3 or 4 toxicity, technically, we have to stop the Imfinzi, and we will not resume it until the patient is treated with steroids and those immune-related adverse reactions resolve to a grade 1 or less before we continue again. So technically, this is another way to show them. I will not spend more details on it, more time on it, but these are very specific, very well specified today about the way to manage the immune-related adverse effects, including the immune-mediated pneumonitis. So I'll add my presentation with few cases of patients that are eligible for Imfinzi, and we'll go through them very quickly just to show some case scenarios. So here I'm presenting Joseph, who's a patient with unresectable stage 3 non-small cell lung cancer, who's 69, had a good performance status. He has a COPD that is treated with LABA. He has a smoking history of 1 pack per day for 55 years and has quit after his diagnosis of lung cancer, as most of the patients do. So technically, he's coming to his doctor to get the education on treatment options. And when we initially diagnosed this patient, he had a stage 3 being a T4 lesion, as you can see right here, with an N1 disease, mainly on the ipsilateral side. So it was a 1 centimeter subcarinal mass with a 7.5 mass in the left upper lobe. The biopsy showed a non-squamous non-small cell lung cancer. The PFTs were okay with an FEV1 of 60%, and his brain MRI was negative, so he was not metastatic. So technically, this patient should be reviewed in a multidisciplinary team, and this patient has an unresectable stage 3 lung cancer, and we decided to go for a curative intent, meaning what I showed you in the first part of my presentation, being the concurrent chemotherapy and radiation. And as per the Pacific regimen, CRT nowadays should be followed by Imfinzi in the absence of progression. So when the patient completed his chemotherapy and radiation therapy, he had stable disease by a CT scan. He had no residual side effects except for a grade 1 cough, which could be related to his tumor or to radiation. His performance status was okay. And technically, when this patient is reviewed in a multidisciplinary tumor board, he should be initiated on Imfinzi as per the guidelines nowadays, as well as the Pacific trial protocol. I will show you a second case, which it's Suzanne. Suzanne has an unresectable stage 3 non-small cell lung cancer. Technically, she's 72. She has a good performance status. Her disease is a little bit different. Her tumor is smaller. However, she has N2 disease because she has contralateral hilar lymph node. It is a non-squamous non-small cell lung cancer. Again, it is important to specify the histologic type. However, non-squamous or squamous histologies can benefit from durvalumab. Her brain MRI is negative. She has no metastatic disease otherwise. Again, upon review of Suzanne's case, the MDT concluded that this patient had an unresectable disease based on the N2 disease that she had, and it was decided to treat her again with definitive chemotherapy followed by Imfinzi in absence of progression. And technically, at the end of her chemotherapy radiation, she had a partial response, which puts her eligible to receive Imfinzi as per Pacific protocol. And this patient should be initiated on Imfinzi again as quickly as possible after finishing her chemotherapy radiation for her to benefit the most from immunotherapy. And the last case I will show you is also another patient with unresectable stage 3. This patient has a 4.2 centimeter mass in the left lower lobe. However, he has N3 nodal involvement, and N3 node will make him unresectable, being at stage 3B, T2 N3 M0. His brain MRI is negative. So technically, again, this patient received 3 cycles of chemotherapy overlapping with radiation, and he initiated Imfinzi 20 days later after confirming the absence of progression. The problem is that the patient did tolerate his Imfinzi very well. However, he presented recently with symptoms of pneumonitis, and technically, the question is how to manage Gabriel's pneumonitis to help him continue the treatment with Imfinzi for the full 12 months, as we said, based on the Pacific regimen. So technically, just...
We are running out of time, please.
Yeah, last 2 slides. So managing pneumonitis is very important. It should be done in conjunction with our lung physicians. So I will not show you the details, but however, most of the patients who develop radiation pneumonitis versus immunotherapy-related pneumonitis were able to be treated and to continue their Imfinzi protocol. We have very specific guidelines for this. I will not go into the details, but it is important just to keep in mind that those patients should be considered to receive durvalumab after completion of chemotherapy and radiation, because it really makes a difference. And those are kind of curves that we like to see in oncology, because we know that we're doing the best for our patients. So with this, I'll finish my talk, and I'll be happy to take any questions. Thank you very much for listening.
Thank you, Dr. Hadi. Dr. Hadi Ghanem again presented for us the symposium on Imfinzi and how it's really a new way to cure in stage 3 non-small cell lung cancer for responders. So I see there is no question from the audience. No, personally, I have at least 3 questions, but because we are out of time, I will ask it by phone directly to you, Hadi. Okay. So thank you very much, and I will leave the floor for my co-chair, Dr. Ralph, please.
Thank you so much.
Hello, everyone. Thank you, Dr. Ghanem, for this very interesting presentation. It's now my pleasure to introduce to you a very good friend of mine, an excellent, a great person, and an excellent pulmonologist, Dr. Mirna Waked. Dr. Waked is a full-time clinician and intensivist at St. George Hospital University Medical Center. She's also a professor of clinical medicine at Balamand University Faculty of Medicine in Beirut. Dr. Waked is also an ERS board certified in adult respiratory medicine. She is the 2 times past president of the Lebanese Pulmonary Society, an author of 80 publications in respiratory medicine, and a reviewer for International COPD Journal and Journal of Asthma and Allergy. Dr. Waked is also a gold member representing Lebanon starting September 2018. Dr. Waked will be talking to us about the side effects of immunotherapy, mainly the respiratory ones. And so, Dr. Waked, the floor is yours.
Thank you very much, Dr. Nami, for this nice introduction. I want really to thank the organizer for this invitation. So we're going through the lung toxicity of immunotherapy in the locally advanced non-small cell lung cancer. Just a reminder, because the previous speaker had alluded to the mechanism of action of this novel class of therapy called immunotherapy. It is different, definitely, from chemotherapy, and it has a unique mechanism of action, and by that it has a different adverse event profile and different management for the AEs. So as we just to summarize and simplify the way to look at this kind of novel therapy, it really blocks the PD-1 receptors on T cells and the PD-L1 on the antigen presenting cells, and also the CTLA4 receptors. So it is also called not immunotherapy only, but it is called checkpoint inhibition of the tumor. So these have dramatically changed the landscape of cancer treatment. And if we go to see all the indication for checkpoint inhibitors, we see that it is indicated in such a variety of cancers, and really on top of the list is the non-small cell lung cancer. So the incidence of the adverse event is considered as always, let's say, the same percentage of side effects, whether we are using the CTLA4 inhibition or the PD-1, PD-L1 inhibition. And naturally, the incidence of side effects would be higher when we are using a combined therapy. So the risk of pneumonitis is definitely something we need to be aware of and really familiar with. So the risk of pneumonitis, if we take it by checkpoint inhibitors, the old studies alluded to the fact that the risk is higher when we're using the PD-N1 and PD-L1 inhibitors versus CTL4 inhibitors. However, there are new studies that are showing that there is no difference in the percentage of risk for side effects. By disease type, also used to know that maybe in those who have lung cancer has more propensity to have side effects, pneumonitis from the immunotherapy. However, also recent studies showed similar rates of side effects. So let's go, just for the sake of simplification and very, let's say, the normal or our usual practice, a 65-year-old female patient undergoing the treatment with durvalumab for the stage 3 unresectable non-small cell lung cancer, So as we know, it is indicated wherever the disease is not progressing following concurrent platinum-based chemo and radiation therapy. So she received 6 doses, and after the 6th cycle, she started developing cough and dyspnea, and the CT showed infiltrates and air bronchogram. So just to be very simple and to really have quite a practical approach for this. So at a general management principle, we have some very important points to go through. So first, whenever we are in front of this case, we need naturally to rule out competing diagnosis, any other possible infection, progression of the disease, any comorbidity. Second, we need to suspect also an autoimmune toxicity. We need not to forget that these therapies can also have endocrine toxicities and other potential toxicities rather and other than the lungs. And we need also to grade the toxicity. And we need to go into details how to grade the toxicity on the lung. So grade 1, it needs only supportive care and consider drug withhold. Grade 2, we need to withhold the drug and start a low-dose corticosteroid, 0.5 to 1 milligram per kilo per day, and consider reintroducing the immunotherapy if it resolves. And grade 3 to 4, we need to discontinue the drug. And this is very important, to go for high-dose steroids and taper it very slowly over 4 to 6 weeks until it goes back to grade 1. And if we have a resistance to steroids, consider additional immunosuppression for pneumonitis. So pneumonitis has no very specific symptoms as you can expect. It gives cough, dyspnea, chest pain, fever, and also you need to grade the pneumonitis per se. So in case of grade 1, it is asymptomatic, it is confined to one lobe, or less than 25% of the lung parenchyma, and we need just to clinically observe. If it is grade 2, it is more than one lobe, confined to 25 to 50% of the lung parenchyma. It needs a medical intervention, and we need to limit the instrumental activity of daily living. In grade 3, we have severe symptoms. Hospitalization is required. It involves more than 50% of the lung parenchyma, and we need, the patient is in need for oxygen. And finally, the grade 4, severe, life-threatening, respiratory compromise, urgent intervention is indicated, such as intubation. So what about the percentage of these different grades of pneumonitis? So if we just consider all patient cases, meaning those who are on monotherapy or combination therapy, you see luckily that the percentage of grade 1 is the highest, luckily, and then followed by the grade 2 and less 23% grade 3, and luckily the grade 4 and grade 5 is around 2% only, and this is very rare. If we just check for the monotherapy, the grade 1 and grade 2 are equal percentage, grade 3 is less than in the combination therapy, and for the combination therapy, it is the grade 3 that goes higher in this case. What about the timing? When do we expect to have a pneumonitis? Considering all grades of pneumonitis, you see that all the pneumonitis are occurring around the 3rd or 6 months of the treatment, but doesn't rule out the fact that some of the side effects, pneumonitis, can occur 1 year or more than the start of the treatment. Grade 1 and 2, it's the same pattern. Grade 3 is, however, more prevalent in the precocious phases of the treatment. The radiological features are also variable. We can have a pattern of cryptogenic organizing pneumonia, ground glass opacities, hypersensitivity pneumonitis. We have interstitial pattern, and also none otherwise specified. And the intensity or the severity of these infiltrates can be mild in most of the cases, moderate, less frequent, and severe. So if we can come back or go back to our patient, it has been considered pneumonitis and treated with oral steroids. However, no improvement was there. So she underwent a bronchoscopy, and the findings confirm the diagnosis and may show one of the more of the following. So either it is a diffuse alveolar damage with eosinophils, or organizing pneumonia, or interstitial lymphocytic infiltrate with scattered granulomas. So these are the variable pathological features. The cellular interstitial pneumonitis are the most frequent. Organizing pneumonia with the buds intra-alveolar and in the alveolar duct, diffuse alveolar damage, and so on. So we need to have an early management algorithm when we're facing such patients. And we need to have, first thing, to grade the patient from the asymptomatic one until the 3 to 4 severe life-threatening, worsening hypoxia. And in this case, we have investigation that goes from radiological imaging through the microbial assessment when necessary, until the ID consult, bronchoscopy, and case-by-case analysis. The management is from holding immunotherapy monitoring only, through also possibility of low dose of prednisone monitoring, or discontinuing the immunotherapy with a high dose of steroids and maybe prophylactic antibiotic. So if the patient is in the grade 2 and is improving, going back within 3 days to a normal situation, we can consider resuming immunotherapy for the next dose. If it persists beyond 3 days, we need to go for the steroids and have very slowly tapering over more than 1 month. After the symptoms in grade 3 to 4, if they improve, we again have to taper very slowly the steroid. But if we have a corticosteroid-resistant pneumonitis, we need to consider additional immunotherapy. And in this case, the choices are for either infliximab, 5 milligram kilo for 1 dose, or mycophenolate mofetil, or IVIG for 5 days, or cyclophosphamide. So we need to optimize immunosuppression when we are facing an anti-PD-1, PD-L1 pneumonitis. We need to be very, very cautious, and we need to have a systematic approach using at day 1 of steroid refractory pneumonitis, this CT, maybe the bronchoscopy and BAL, and the oxygen saturation, and the outcome measure. We need to choose between any infliximab or IVIG, just for the sake of example, and we have to evaluate the situation at day 14. So definitely pneumonitis is a challenge when we're using anti-PD-1, PD-L1 treatment for cancer. And what we know till now, that the patient who received TNF inhibition after steroids for grade 2 pneumonitis had poor outcomes. And the choice of immunosuppression beyond steroid is based probably, and the most of the cases, on the colitis experience as a side effect. Bronchoscopy is by case. It is done whenever you think that it would really rule out an infection versus the progression or the pneumonitis. We still don't know exactly what are the mechanism of pneumonitis. We have prospective correlation analysis in patients that are waiting, not done yet, and the survivor will be lower among the patients who develop pneumonitis, still an open question. What about the experienced clinics, oncology clinics, or team that take care of such patients? It's very important to recognize the adverse event. So a patient is coming to a second cycle of immunotherapy. We need to be aware that if he has or she has a shortness of breath or fever or lung infiltrates, we need to have a heightened awareness leading to monitor this patient to see if there is a rapid decline and to consider if we need steroids or adding other immunosuppressant. So the key learning from those clinics that are using this kind of drugs is that AEs from immunotherapies can manifest as typical cancer symptoms. We need to have high awareness, high index of suspicion for pneumonitis. Other varying experience with immunotherapy would be that you have a team, you have a nurse, you have pulmonologists on the case, an oncologist. They are receiving the patient, and the patient is calling, let's say, a nurse, and the request modification and is reporting shortness of breath. So maybe one of the members of the team would say, well, let's modify the COPD medication. But normally you need to have a specialist, the pulmonologist, seeing the patient. So the team members need to be aware that this may be a symptom of pneumonitis and need to alert the cancer team, meaning that we need to know that the symptoms of immunotherapy could be really very well mistaken by the patient and the providers as something related to another health condition. The multidisciplinary team is key. And in the center, there is a patient and the other really providers for this. Seeking a consultation is important, a multidisciplinary approach, important to overcome the communication gaps we have, and also to start to be familiar with the experience of the immunotherapy and its side effects. The lessons also would be what to do in case of a pneumonitis that responded to a therapy, re-challenged after pneumonitis, re-challenged with this drug, but again developed pneumonitis again. We don't know yet what would be the best to be done in this case, and the key learning would be that the providers will need continual education as the field is moving very fast. The patient as a team member must be a team member, must be aware of the side effects, must be also in the choice and the decision of the drug. And also the team also must be very well aware and informed of the best practice and the best communication. So, and to conclude that pneumonitis is one of the most common autoimmune side effects of checkpoint inhibitor, especially the PD-1 axis inhibitors. We need to have an early recognition, and it is key. The practitioner should have a low threshold to hold drug and initiate steroid. The steroids are given at 1 milligram per kilo or higher and should not be tapered quickly. And we need an expert consultation and multidisciplinary approach. And finally, for patients having a pre-existing interstitial lung disease, we don't have a real and absolute contraindication to use these immunotherapy, but it is a reason to have a pre-treatment consultation with pulmonology. And with that, I thank you very much.
Thank you very much, Dr. Waked, for this very interesting talk. I would like to ask you one question, if you please. We know that some type of adverse events seen with immune checkpoint inhibitors can happen a few weeks or months, even after the patient has finished the treatment, especially with colitis, for example. Yes. Do you think the same thing could happen with the pneumonitis?
Yes, apparently, yes. There are also cases of side effects appearing, let's say, most after 6 months or after stopping the medication. So you need to have a high index of suspicion in this case and always have a way to differential diagnosis. And then if you don't have, you ruled out an infection, you ruled out the progression of the disease, you need to think about pneumonitis and toxicity from the checkpoints.
So it's important to keep that in mind.
Yes, very important.
I think we have one more question from Ellen Abyad. So the question says, in relapsed cases, can't we keep the patient on preventive dose of steroids during immuno?
Yes, this is a very good question. So can we put the patient on steroid? I will answer you, Dr. Abyad, by a personal experience, because it's an expert opinion. As you saw in this presentation, there are no really guidelines. But when a personal experience with 2 patients on immunotherapy and developing severe pneumonitis, we re-challenged them cautiously, but we tapered the steroids very slowly on 6 months. And we kept them on very slow and very small dose of steroid. This is very just a personal experience and expert opinion.
All right. Thank you very much.
Thank you.
So I think we can conclude this session since we have no more questions and proceed with the next session.
Thank you
everyone for attending.